Minority stress theory explains why LGBTQ2+ youth experience higher rates of mental health distress without locating the cause in identity itself. Stress emerges from repeated exposure to stigma, rejection, and exclusion across social environments. For at-risk youth, these stressors are often ongoing rather than isolated, creating cumulative psychological burden. Framing distress through minority stress allows therapists to begin assessment and intervention from a position of validation and ethical clarity. External minority stressors are events and conditions imposed on youth by others or by systems. These include direct experiences such as bullying and rejection, as well as structural factors like unsafe policies or lack of affirming services. Exposure is often repeated and unpredictable, which increases psychological impact. Recognizing these stressors helps therapists avoid misattributing symptoms to individual vulnerability rather than social harm. Over time, external stressors shape internal experiences. Youth may anticipate harm even in neutral settings, monitor their behavior to avoid exposure, or suppress aspects of themselves to remain safe. These strategies are adaptive responses to real risk, not signs of weakness. However, chronic vigilance and concealment can contribute to anxiety, depression, emotional exhaustion, and identity fragmentation. Therapy must acknowledge both the necessity and the cost of these survival strategies. For many LGBTQ2+ at-risk youth, minority stress intersects with traumatic experiences such as abuse, homelessness, or system involvement. Trauma may not stem from a single event, but from prolonged exposure to unsafe relationships and environments. Behaviors often labeled as oppositional or resistant are frequently trauma responses shaped by prior harm. Trauma-informed care requires understanding these responses as protective adaptations rather than pathology. Applying a minority stress framework shifts clinical practice toward ethical, trauma-informed care. Symptoms are understood as meaningful responses to lived experience rather than internal dysfunction. This perspective supports accurate formulation, reduces misdiagnosis, and strengthens the therapeutic alliance. When oppression and discrimination are explicitly named, youth are less likely to internalize blame and more likely to experience therapy as a space of recognition and repair.